Welcome to SpectraCell's Thursday night webinar program, Weight Loss and Beyond, Clinical Strategies for Effective Body Weight Management, presented by Dr. Tom Bilella. This presentation was pre-recorded due to scheduling conflicts. If you submit questions in the Q&A box, we will collect them and respond appropriately. Enjoy the presentation.
And welcome everybody. This is Dr. Tom Bilella. I'm so excited and pleased to be doing a webinar here on weight loss and beyond, some clinical strategies for effective body weight management dealing with this obesity crisis. Thank you, SpectraCell, for this platform to educate other practitioners on how to help tackle this globesity epidemic. So who am I? Well, I am Dr. Tom Bilella. I have a very successful practice in Red Bank, New Jersey, where I've been doing a functional nutrition practice for about 14 years. I do have a master's in nutrition, certified sports nutritionist, a diplomate in American Clinical Board Nutrition, certified nutritional specialist. I am the chairman of the Nutrition Education Council here in New Jersey. And of course, I'm a chiropractor, still treat friends and family, but I sold my practice about 15 years ago now to pursue a cash practice with functional medicine. And I've been using SpectraCell Labs for well over 5 years now. So our objectives for this are going to be to understand the factors that are driving body weight regulation, especially as it relates to losing weight and rebound weight gain. And we're going to really focus on metabolism, not so much in the microbiome for this particular talk. The clinical management of those patients who are overweight, and there are millions of them. Of course, look at potential macronutrient modification with respect to weight management with a focus on low-carb diet approaches and a ketogenic platform. And of course, we're going to talk about the vitamins and minerals, micronutrients associated with diabetes. So, with obesity, we're going to look at contributors to this epidemic and the consequences it's having on us, both financially and, of course, from a healthcare standpoint. So let's talk about the basics. So obesity and being overweight are defined as a systemic disease where, of course, excessive accumulation, abnormal accumulation of body fat, devastating health and financial tolls on individuals and our society. And yes, clinicians are at the forefront of this epidemic, and in most cases with limited time and resources. So in order for us clinicians to tackle this obesity epidemic, we need evidence-based treatments that are practical, affordable, and feasible that can be implemented in a real-world setting. So hopefully what we're going to share on this webinar is going to help you with those. So let's talk about obesity. It can be defined in different ways, including, of course, a disorder of fat mass and where it's actually on the body. We have excessive energy being stored with obesity. Now, if we look at carbohydrate stores, even a thin person will have about 2,000 calories available stored energy in the form of glycogen, mostly, of course, in the liver and the muscle. Protein, you can have up to 25,000 calories stored in muscle, but of course, that is not your best option for stored energy. But even a thin person can have up to 60,000 calories of stored energy. An obese person, 200,000 calories. So the key here is tapping into these calories and burning fat. So it is truly a dysfunction of the adipose tissue itself. It actually goes through a remodeling. Normal adipose tissue, a certain size and a certain function of the body. When adipose tissue goes through hypertrophy, well, that's when you start to see problems. You start to see a reduction in adiponectin, an increase in pro-inflammatory cytokines. We're starting to see more hypoxia and fibrosis, increase of free fatty acid release in the bloodstream, and certainly insulin resistance. So this leads to some uncontrolled inflammation, typically silent inflammation, low-grade inflammation, and that leads to metabolic disorders, such as insulin resistance, prediabetes, diabetes, and into metabolic syndrome. And what we now know that there's crosstalk between adipose tissue and other organs. So, the adipose tissues are speaking a dirty language here that you don't want the other organs to hear. And once that adipose tissue goes through hypertrophy and you start to see these changes in the chemical makeup of this fat cell, that's when we run into some problem, including insulin resistance. And of course, fat has distinct deposition patterns. We know about the apple and the pear, okay? And adipose tissue is indeed an endocrine organ. And when it's more in the visceral area, it is more endocrine-like, if you will. Visceral and subcutaneous abdominal tissue are different. The adipocyte, or the visceral fat, more inflammatory cytokines, more associated with insulin resistance and atherogenic dyslipidemia. We know what that is. Too much fat in the blood, that can certainly cause plaquing. So where the fat is on the body definitely matters. And of course, we know about waist circumference as an important surrogate measure of abdominal and all visceral fat. 54% of the U.S. population have an elevated waist circumference, 43.5% of men, and about 65% of women. And a sad statistic, folks, in women, the figure is rising to a greater degree than even expected on a BMI. So we are in a crisis here. It is not getting better. So what is some of the epidemiology of the obesity epidemic? Well, what is the prevalence? 37% of Americans are obese. Now, some reports say it is starting to stabilize. It's been rising significantly since 1980, but certain sectors of the population, like teenage girls, are getting more obese. Is it linked to gender? Yes, indeed. 40% of women and 35% of men have a BMI over 30. 10% of women, compared to 5.5% of men, a BMI over 40, which is significant obesity. Very interesting. Which country ranks the highest of number of their population, percentage-wise, with obesity? I would have never guessed it. If you said Egypt, you win. But the sad fact is, United States held the highest level of childhood obesity. Very scary. And is it linked to social, cultural, environmental factors? You betcha. Stress, busy lifestyles, hectic work schedules, sleep deprivation, and of course a high availability of energy-dense, low nutritional value foods, empty calories, sodas, fast food are everywhere. And yes, they hijack your brain. They become very addictive. Well, we know there's a lot of factors that contribute to the pathogenesis of obesity. So we know there's developmental factors. Sleep has a lot to do with it. Genetic factors, yes, there is an obesity gene. Epigenetics, the expression of your genes based on what you do them. How much physical activity is the person getting. Environmental factors like BPAs, hormone disruptors. Certainly your dietary composition and eating behavior. People eat fast, tend to be more obese. Neurological, physiological processes, medications. Oh yeah, medications. Many medications have a side effect of weight gain. The gut microbiome, we're learning all the time now how the gut microbiome has a significant influence on hunger and other regulators. Underlying infection, yeast overgrowth, viral load can definitely affect your weight. Endocrine disrupting chemicals, which we discussed. And certainly social and economic factors. Lower socioeconomic status people can be consuming more empty calories with a higher prevalence of obesity. So what are the consequences of increased body fat? Well, we know there's many. Cardiovascular issues, including stroke and heart attack, respiratory issues, musculoskeletal issues, including osteoarthritis, myalgias, back pain, GI, reflux, hernias, gallstones, and we can't leave out psychological issues, depression, self-esteem, prediabetes, type 2 diabetes, and then there's gender-specific. Women tend to get hyperandrogenic, right? Hirschism, I can never say that, acne, polycystic ovarian syndrome, again, are related to obesity, insulin resistance, etc. And interesting, women tend to get higher androgen levels, and men tend to get lower androgen levels. So I once heard a speaker talk about, when you're 25 years old, a man and a woman in a car, the man's driving. At 70, 75, the woman's driving. Typically, the woman has more testosterone at 75 than a man does. Very interesting. So there are many consequences with obesity. We know this. A lot of times they're called comorbidities, but this is draining our society. It's draining our system. So we need to do something about it. All right, so if we start to reduce weight, what we do that lowering weight reduces morbidity and mortality. Here's good news. With diabetes prevention, if you're overweight, losing 3, 5, 7% of your weight can reduce the risk for diabetes. Blood pressure, high blood pressure, lose 5% of your weight, 10% of your weight, you can start to reduce blood pressure. Dyslipidemia, 3%. Elevated A1C, 3%. Fatty liver, lose 10% of your weight, see a significant improvement there. Sleep apnea, we've seen this before. Osteoarthritis, stress incontinence, GI. So what we see here is a sweet spot around 5% up to 10% of losing your body fat or gross body weight rather can make a big impact on comorbidity and save us all a lot of money. Weight loss of 10 to 50% could lead to a gross Medicare savings of $10,000 per person over 10 years. It's probably even more than that. So there's the good news. We can save money by chopping off some body fat here if we can teach people what they need to do and give them some reasonable, feasible strategies. All right, so how do we really assess obesity and improving outcomes? So we know that BMI is still kind of the gold standard, and it's kind of weird. If your BMI is over 25, you're overweight, over 30, you're obese. I'm 53 years old, about 5'10.5", about 214 pounds, and I am obese, but on my body comp analyzer, around 17%. The average linebacker in college has a BMI of about 33. So we know that BMI does not take into account lean mass. Then there's percent body fat, which is my preference. Women over 32%, obesity. Men over 25%. And there is essential fat, ladies and gentlemen. Like a man should not be like below 3, 4, 5% body fat, and women 10 to 13%. So that's another criteria. And then we can just do waist circumference, which is real and valid. Men over 40 inches, women over 35 inches. A little bit different for Asian men and women. It's about an inch less because they are smaller people. So a simple measurement of the waist circumference will give you indication of visceral fat and risk factors. So let's talk about how we can support these people in clinical practice with weight management. And as always, the first consideration with a patient is one size fits nobody, right? Some factors that you must consider before reviewing or kind of going over a macronutrient distribution, how much protein, carbs, and fat an individual should be consuming, medical history, fasting glucose, fasting insulin, certainly hemoglobin A1C, to get a sense of their carbohydrate tolerance, their carbohydrate tipping point, give you an idea of how many carbs they can potentially handle per day, per meal. Ask questions. What's been your long-term adherence? Can you stick to the diet? Because we know anyone can lose weight, but the trouble is keeping it off. Permanent weight loss is really still, what we're after, and that's been the hard part. Have you had success losing weight in the past? Cultural considerations. What do they eat? Gene-nutrient interactions related to macronutrient intake and weight loss and maintenance success. So we're learning more about the importance of genes as it relates to predicting protein, carbs, and fat. I think there's more work that needs to be done, But if you just look at these parameters such as glucose, waist circumference, weight loss success in the past, can really help give you information to help, put together a personalized program. So it's all about weight maintenance. That is the challenge. People are losing weight all the time, and I once heard, I wish I could get back to the weight I was before my first diet. Very common. All right, so despite benefits of weight loss, only 1 in 6 people keep the weight off for about a year. That's 16%. Health records of 76,000 men and 100,000 women, again, they're not keeping the weight off. So we know that is the big challenge. So we have the statistics on this, but I don't need to read the stats. We know this, that keeping the weight off after this quote-unquote diet has been the problem, and oftentimes there's rebound weight gain, and in many cases, you're putting on more weight than you lost initially. So what's going on here? What happens after weight loss? Well, it's just not lack of willpower, folks. There are significant changes in your chemistry. So you see the bigger person gets smaller. As the person loses weight, even if they keep the muscle, there are still going to be changes with your leptin levels, your ghrelin levels, GLP-1 reduces, which is an important satiety hormone in the gut. We start to have less or lower resting metabolic rate, less sympathetic nervous system activity. So there are major changes, significant changes physiologically. Okay, appetite-related hormones, I said that. So understanding this is going to be extremely important to support a patient client in the weight maintenance phase. But of course, we're going to talk about some proven tactics and strategies in which to do that. And it's always important to tell the client, this is the hard part. It's the weight management. That's where we need to continue to support you. So we now know that there are certain, considerations or certain strategies, as I said before, for keeping the weight off. And this is based on data. So on the left, we see a decrease in leisure time sensitivity and limited TV viewing, less than 10 hours a week, is going to help with weight maintenance. So less TV time. Dietary restraints, stay on that gluten-free diet. Weighing in, every day, every other day, once a week, getting that feedback. Volitional physical activity. 80 minutes a day, to me, that's a little excessive. I don't know too many. Personally, and many of my clients, eating breakfast becomes an important action step for keeping the weight off. Self-monitoring your dietary intake. A lot of people will start charting their calories at first, MyFitPal, or charting their workout. If you continue to do that, that's a key consideration. And limiting sugar-sweetened beverages. Yellow. Yeah, you can't go back to drinking soda, even if it's diet. Other considerations for success, meal replacement shakes, okay? 1 or 2 shakes a day. So now we know what it's going to take. So this should absolutely positively be communicated with your client when they've taken off hopefully 5-10% of their body weight, whatever they need, seeing good changes in their blood chemistry. But, hey, pick out 3, 4, 5 of these things that they need to do to continue to keep the weight off. So what has been shown to work and prevent that weight gain? Well, unless you've been living under a rock, the ketogenic diet is popular and it works, and I do use it to some degree in my practice. There is certainly a subset of people who need or do fantastic on a ketogenic diet. So we are going to talk about that, for long and short, long-term approach to this, with homeostatic and physiological approaches to kind of keep some of those changes we talked about at bay, especially with the hunger hormones. Using tools such as meal replacement shakes, smartphone applications, monitoring things are all effective at keeping the weight off after you lose the initial weight. So let's dive into ketogenic diets as one approach to management of weight. So the ketogenic diet now does have a long track record, almost 100 years now. Back in the 1920s, ketogenic diet was recognized for its popular treatment of epilepsy. In the 60s, recognized as an alternative fuel source for the brain. Like the brain will use ketones as a fuel, a fourth macronutrient, if you will. Okay, looking at for starvation, role of ketones and how the ketones help when you're in starvation mode. And then in 1971, medium chain triglycerides, the oils, introduced as another treatment for epilepsy. Use of ketogenic diets and exercise, they found that there was no loss of physical performance once the athlete was what we call keto adapted. So kind of a breakthrough in the early 80s that you don't need carbs for athletics if you keto adapt. 2002, low-carb approaches such as Atkins are going crazy, very popular, and they worked. 2000 onward, now, again, more interest in ketogenic diet for epilepsy, but what I really like, I think it was in 2004, using exogenous ketones, drinking ketone salts to mimic a ketogenic diet. And of course, that's very popular now, and they do work. So there's been a long history of ketogenic diets, including up to 2017. Reviews of cancer indicates more robust, consistent clinical results using ketogenic diets with cancer treatment. And beta-hydroxybutyrate, as one of the three main ketones, has been studied the most. So what the heck are ketones? Well, ketones are produced in the liver when you're breaking down fat, and usually you have to be in a very low-carb diet to get into a ketogenic state, which can take a couple, 3 days. Ketosis is defined as where your ketone bodies get to about 0.5 millimolar per liter in your blood, and that's due to a low glucose availability. Now, a ketogenic diet, traditional ketogenic diet, is low carbs, less than 50 grams total, 70% fat, 20% protein. Now, if you're using a ketogenic diet for epilepsy, sometimes even a stricter adherence to even lower carbs. So that is the basis of ketones in a ketogenic diet. And here's what's happening with this keto adaptation. So you go on a low-carb diet, high fat, get enough protein. That's going to drop your glucose and insulin way down, right? That's now going to cause a release or lipolysis, release of fat, pardon me, from the fat cell, the adipocyte. That fat is going to go into the liver, and then that mitochondria is going to break down these fats and start to produce ketone bodies. Beta-hydroxybutyrate, acetone, and acetoacetate will start to circulate in the blood, and the brain will suck these up, and so will the muscle, and start to use those to shuttle those in to your Krebs cycle and start making ATP from ketones. So can we use a ketogenic diet for weight management? Well, the studies say absolutely. So in a study with men BMI over 30, over 24 weeks, what we're seeing here was about a 12-kilogram reduction, which is about 26 pounds in 24 weeks, on a low-carb ketogenic diet, compared with about 14 pounds on a low-fat diet. So almost doubling the fat on a ketogenic diet, and that's been what I see clinically. And 61% of patients or recipients in the study on a low-calorie ketogenic diet lost 10% of their initial body weight in 24 weeks. Now, again, that's a magic number as we looked at comorbidities. If you can shave off 10% of your weight, you're going to greatly reduce, these other factors, diabetes, digestive issues, etc. So 10% in 6 months, pretty darn good. And what we know is that there's a significant change in appetite on the ketogenic low-carb diet after you go into this keto adaptation, getting your blood up to 0.5 millimolar. So again, studies are showing that they're less hungry, and I see this in my patient base, and I've done it myself. When you get those ketones up, you just don't have that same hunger response. And oftentimes it is this hunger response when you've lost the weight that gets people off track and back to poor behavior, that reptilian brain kicking in going, feed me. So it's not always lack of willpower. These hormonal changes are very powerful. But you get the ketones up in your blood, get the insulin down, get the glucose down, and your appetite is really, really regulated with a high satiety factor. So how do ketogenic diets, relate directly to risk factors? Well, we know it helps lose weight, almost double than a low-fat diet, more than double. Reduction in lipogenesis. You're not going to make fat cells. You need insulin to make fat cells. Increased thermic effect of protein. So you need protein to get more of a thermogenic effect. And, of course, that powerful appetite hunger reduction. It helps reduce hemoglobin A1C. For me, if I have someone with a high hemoglobin A1C, we definitely entertain a very low-carb ketogenic diet, lower insulin levels, and reverse of hepatic insulin resistance, which is where insulin resistance starts in many cases. And now the good news is we're seeing an improvement in many cardiovascular risk parameters. Okay, reduced endogenous cholesterol synthesis, making less blood cholesterol and triglycerides. You can definitely see a transient increase in in LDL particles on a ketogenic diet, so something you want to continue to track. But oftentimes your overall risk patterns or parameters on a ketogenic diet reduce significantly. So if we're going to talk about ketogenic diets, we have to talk about medium chain triglycerides, also known as MCT. We learned that MCTs were 6 to 12 carbons, caproic, capric, and lauric acid. But a lot of research has really shown that really your true MCTs are 6 to 10 carbons, where the lauric acid is really not as well utilized as an MCT for ketone production. What happens in the liver, these medium chain fatty acids can cross the inner membrane, get into mitochondria, and you can start to manufacture these ketone bodies, which will help continue driving the Krebs cycle and electron transport chain. So we definitely have some studies that show taking about 9.2 grams of MCT a day, mainly the C8 and the 10 for 12 weeks, increase circulating ketone bodies to a much greater extent than long-chain triglycerides. Other studies show that, again, taking the MCTs reduces body weight, total body fat, and waist circumference. MCTs, the C8 and the C10, increases energy expenditure and lipid oxidation, which is fat burning, and helps with satiety. So again, the studies are clear. MCTs really help with what we're looking for: satiety, fat loss, and energy. So if you're going to approach a ketogenic diet for yourself or a patient, you got to monitor certain considerations. So again, standard is 70% fat, 20% protein, 10% carbs. You can do some ketogenic testing or ketone testing. Urine is the easiest and pretty much the most popular. Now, what does happen very commonly, once the patient goes into keto adaptation, where they're getting more used to, if you will, upregulating enzymes to use ketones for fuel, your body gets smart, and oftentimes you don't even urinate the ketones, you're reabsorbing them. So after a few weeks or months, I have patients going, "Hey, Dr. Tom, I'm not in ketosis. My urine is not in ketosis anymore." But I'm like, "But how do you feel?" "My hunger's, I'm fine, I'm losing weight." I'm like, "Actually, you're probably still in ketosis, but you're just not getting ketones in the urine." The most accurate is the blood finger stick measurement, looking for circulating beta-hydroxybutyrate levels. It's a little inconvenient, gets a little expensive. What is really, really a good way to go is the breath measurement, which actually takes about 2 minutes. You blow it into your computer and can give you a little graph representation with colors and give an indication if you are in ketosis, if you're in the right spot. So they all have their value. Anyone who goes on a ketogenic diet, I definitely recommend that they monitor this by doing your ketone testing. Now, you have to be also safe here. Make sure prior to doing it you have a consultation about the strict adherence to the diet, certainly no alcohol, and a careful medical history. Make sure they have good kidney function and liver function. Make sure they have, understand their lipid profiles. So some people have to be careful if they have really high lipids and going on a 70% fat diet, although most research shows it will help. But you still have to be responsible and potentially 6 to 8 weeks later do more blood work. There can be some adverse events, very mild and transient, headache, GI distress, some cramping. Oftentimes using some minerals, sodium chloride, magnesium, potassium can help offset that. Highly recommend vitamins and minerals during this ketogenic diet. And that's what you got to do is you got to monitor these things. But my experience personally has been that patients do extremely well, and it really helps appetite. And patients are excited when they're losing 1.5 to 2 pounds a week or more, not a half a pound. All right, so that was a little overview of weight, obesity, the ketogenic diet, MCTs, as a way to help support your patients. I want to kind of dive into something that is important as well. It is diabetes, especially type 2 diabetes, and certainly talk about nutrients that can play a role in improving those with diabetes and pre-diabetes. The first one I'd like to talk about is niacin, obviously a B vitamin. The niacin can certainly help the pancreatic B cells from autoimmune destruction. So in some cases, this can help prevent that type 1 or type 1.5 diabetes. So consider niacin. And of course, it's also involved in DNA repair. And may act as a weak antioxidant of nitric oxide free radicals as part of the glucose tolerance factor, and may retard the development of nephropathy or kidney issues if someone is a diabetic. Dosing can be between 25 and 50 milligrams per day based on the individual. And certainly one of my favorite nutrients with diabetes, pre-diabetes, and resistance is absolutely chromium. Will increase activation, the AKT phosphorylation. It will increase or improve intracellular insulin-dependent proteins that will uptake and get that glucose in the cell. No doubt about it, really improves that insulin sensitivity, may even increase the number of insulin receptors. So this has been, for me, a home run for close to 30 years of clinical practice. I test for chromium in SpectraCell. I use chromium, and it can really be a home run. If you have your patients on insulin, make sure they monitor themselves because this can be powerful. As it says here, it may reduce their requirement, can help hemoglobin A1C, even help with some of the blood fats. And yeah, positive effects in 6 to 12 weeks that you can literally measure on blood work. So of course, consider chromium as one of your very important nutrients for diabetics. But chromium has a flip side. You got to be careful of the dose. It can be, toxic to the kidneys and the liver. In some rare cases, rhabdomyolysis, psychiatric disturbances. Sometimes their blood sugar will drop too low. That could be an issue. And always, you got to consider nutrient versus nutrient from an absorption standpoint. They can decrease zinc absorption, and we're going to find zinc is also important for insulin sensitivity. So in many cases, if I need someone on zinc and chromium, take them at different times a day. Can compete with iron for transport. And vitamin C and aspirin may increase absorption. So that's actually interesting. So again, I test for chromium on the SpectraCell report. If they need zinc as well, definitely separate times. Well, there it is, magnesium. Maybe my favorite mineral of all time. Many people are low in magnesium. So high prevalence of hypomagnesemia and lower intracellular magnesium. So if you're checking serum magnesium, if it's low, you're probably low inside the cell. But I like to check red blood cell magnesium and certainly use the SpectraCell looking at the white blood cell magnesium as relates to depleted magnesium levels, but magnesium is also critically important. And here's why. It plays a key role in regulating insulin action, something known as insulin-mediated glucose uptake, again, getting the glucose into the cell, vascular tone, which is critically important in your bloodstream. So there's a lot of critically important components magnesium plays. We know that magnesium is responsible for over 300 enzymes in the body, including influencing intracellular signaling and processing. Again, it's a big communication between what's going on in the cell and at that cell membrane level. So again, test your patients for magnesium. Dosing, standard is 400 to 600 milligrams. I have a rule of thumb. Take your body weight, multiply by 0.03. So if I'm 215 pounds times 0.03, I'd recommend about 645 milligrams a day, and that's what I take. It's often low in diabetics, especially if they have a retinopathy, especially if they have neuropathy. So this is critically important. It helps prevent calcification of blood vessels, controls blood lipids, prevents platelet aggregation. We know that most diabetics tend to have cardiovascular events. So again, magnesium, test it and recommend it. And again, more evidence-based research, inverse relation between plasma magnesium levels and indices of glycemic control in type 1 and type 2. You have a low magnesium diet associated with an increased insulin level and strongly associated with insulin resistance. So that's recapping. You got to talk about zinc. Again, many people in our society are very low in zinc. Zinc deficiency will alter your fat and carb metabolism. Diabetics tend to hyper-excrete zinc. We know zinc is critically important for wound healing, hormone production of hydrochloric acid in the stomach, and some studies show it may protect the beta cells of the pancreas. So test for zinc, test for magnesium, test for chromium, test for your B vitamins, and support the patient specifically. Well, of course, there's vitamin D, which is extremely important for everybody, but it's been associated with type 1 and type 2 diabetes. Living in higher latitudes, north of Atlanta, increased type 1 diabetes. Maybe it's related to vitamin D. Children who received vitamin D 2,000 IU, the reduced risk of developing type 1 diabetes. That is a big deal. It's important for normal insulin release by increasing that transmembrane calcium movement into islet cells. That's the mechanism. So vitamin D receptors have been identified in pancreatic cells, the islets, the beta cells. So vitamin D, critically important. Of course, you can test it on serum. You can test it white blood cells. But we need to really keep our vitamin D levels up. And what I really love about this data here is we got to check children. My daughter, I just checked her vitamin D level. She was about 68. She takes about 1,000 to 2,000 IU a day. So please check children, check their vitamin D. So alpha lipoic acid. All right. Alpha lipoic acid will prevent glycosylation. We know alpha lipoic acid is a intracellular, extracellular antioxidant. Again, will have effect on insulin sensitivity and can stimulate glucose uptake by the muscle cell. And that is what you want, And I often teach my patients, even if they can't do much exercise, squeeze your muscles every hour. Squeezing the muscles will increase insulin sensitivity, glucose uptake, but lipoic acid is, again, when you're thinking about insulin resistance and preventing diabetes, think lipoic acid, or even better, do a micronutrient assessment, test for it. And of course, CoQ10, it's a lipid-soluble molecule. You make it. As we get older, we make less. Can have an influence on blood pressure. Higher CoQ10 levels definitely associated with lower hemoglobin A1C. All right. It's found to be low in many diabetics. Helps prevent kidney issues. And as we know, it's a very powerful antioxidant and can help the mitochondria. So checking CoQ10, critically important. I love checking CoQ10 on my micronutrient report. And we couldn't have a talk about nutrition, about diabetic prevention and overall health without talking about omega-3 fats. We know it helps reduce cardiac arrhythmias, reduces blood clot formation, reduces heart attacks, strokes. We know that also improves insulin sensitivity. I love the SpectraCell report. I like to recommend my patients get their omega-3 levels to about 8% and get that ratio of omega-6 omega-3 about 4 to 1. That is one of the most important health considerations nutritionally I think you can discuss with your patient. If you ain't testing, you just don't know. Well, all right. We went through a lot of information. Hopefully this is valuable about the prevalence of obesity, things you can do to help manage a patient, support a patient with some good information as far as weight management, thinking about using MCTs and a ketogenic diet. And, of course, the role of micronutrients. I'm Dr. Tom Bilella. That's where you can reach me. If you have any questions, please feel free to email me directly. I want to thank all of my friends at SpectraCell for this opportunity. One of my favorite labs. Every one of my new patients gets a SpectraCell and a repeat SpectraCell 6 months later to make sure we continue to personalize our program. So this has been Dr. Tom Bilella. Thank you so much for your time. Bye for now.